I am really pleased to introduce Dr. Karen Fredriksen Goldsen, an incredibly valued colleague here at the University of Washington. She is a nationally and internationally recognized scholar addressing equity and the intersections of health disparities, aging, and well-being in resilient at-risk communities. She's a professor in the School of Social Work at UW, and she's founder and director of the Goldsen Institute for Innovative Research in Health, Longevity, Culture, Sexuality, and Gender. And she is going to talk with us today about health disparities of LGBTQ plus older adults. Thank you so much for coming, Dr. Goldsen.
Thank you. Thank you, Barb, for that introduction, Dr. Wood, and thank you all of you today for being part of this, this discussion today. I'm going to do a presentation, but I really welcome questions. And again, Dr. Cochran, I really appreciate the introduction and the opportunity to share today. So what I wanted to talk to you today about is health disparities of LGBTQ older adults. And I'll also talk a little bit about their caregivers. Okay. This work, again, I want to thank the Northwest Geriatric Workforce Enhancement Center for asking me to speak today. What I'm going to be talking about today really is from a number of our studies and then the application of those studies to future work and to interventions and to practice competencies. So I want to thank the National Institutes of Health and the National Institutes on Aging for supporting the work that I'm going to be discussing today. Of course, the content is my responsibility as the author and does not necessarily reflect official views of NIH or NIA. I would be amiss if I didn't thank my team. This is a research team. It takes an effort, a great effort, to develop the work that I'm going to be talking about today. And our motivation is really to use science and move that science to impact. And I'll share a little bit more what I mean about that as I go along in the presentation today. But these are my colleagues that I work with as part of our research teams. So what I wanted to do is just give a quick overview of what I want to talk about. This is a very dynamic area of study. As you can imagine, sexuality and gender, they are dynamic. Things change over time. And we're gonna, I think that'll be evident today as I talk. I want to show that historically there was actually very limited information about these populations. And while I'll use LGBT or LGBTQ, lesbian, gay, bisexual, transgender, queer questioning, two-spirit, and I just want to say that the community is so much more diverse than a simple acronym. So I think we'll be able to demonstrate that diversity today, because as I talk about health disparities, and then I'll be looking at subgroup differences, and that really shows the diversity in these populations. Then I want to talk a little bit about what are the risk and protective factors. Why do we see these health disparities? And then what can you do as a practitioner or as a researcher? What is your role? And then we'll also look at resources. What resources are available to make sure that LGBTQ older adults are getting the best services, practices, research possible. And again, this will help all older adults, because what we learned, this particular population is really underserved, but I have found what we learn about underserved populations really then helps us better serve all older adults. So that's a bit of what I'm going to be talking to today. And I do encourage you to put any questions as was stated. Go ahead and put it in the chat. So as I said, sexuality and gender identity, there was very little information until recently. And there was kind of this, I want to say, a certain facade, or at least there was a sense of don't ask. And why? Why did people not want to ask, older adults in particular? Because when we looked at population-based data, and for that matter, for a lot of surveys, most did not ask. They did not ask about sexuality, or they did not ask about gender identity. And many people didn't ask. And when we asked people why, most felt that older adults wouldn't understand the question. So if you asked about sexual orientation, for example, people thought, well, older adults, so they asked it up to the age of 49, but they didn't ask it beyond. And that was true for several population-based studies. So they didn't ask the older adults. Again, they thought that they wouldn't understand, or that they wouldn't respond, or that they would drop off. So in other words, they wouldn't complete the rest of the survey. So there was these myths, and it was really about these questions are just too sensitive for older adults. But what we found when we actually looked at this, so in order to get, there was even a difficulty in some cases with funding, because people thought populations, especially LGBTQ older adults, were so invisible, so stigmatized that they wouldn't participate in research. But what we found actually when we looked at population-based data, and Washington State was one of the first to include a sexual orientation measure in the BRFS, the Behavioral Risk Factor Surveillance System. And so we were able to look over time, what happened? And we found that the non-response rates among older adults, so 65 plus, had decreased significantly over an 8-year period. And by decreased, I mean the non-response, those that wouldn't respond to a sexual orientation question. And we think that really reflects sort of this rapid social change. There's a lot of conversation occurring and change in society, non-discrimination legislation, changes in attitudes. But we really see this change in how that people will respond to these questions. And in fact, this just shows over that period, over that 8-year period, how quickly that changed in terms of still, even early on, only 4.7% wasn't responding, but within an 8 years, it was only about 1.5. So very few people weren't responding. In fact, many more didn't respond to more sensitive questions like income. So we've been able to use this and be able to talk. And now these questions, we presented some of this information, for example, at the Health and Retirement survey, and now these questions are being increasingly included. And it's very important because you can't understand the health of a group if you're not measuring it or you're not evaluating it. We did want to understand also, though, how are sexual identity questions, is there a difference by race and ethnicity? Because you'll find in our research, one thing that's been very important to us is understanding these subgroup differences. So sometimes people think of LGBT older adults or LGBT people as sort of this monolithic group, but we know it's not. And we know there's such diversity. And frankly, we did find that Black, African Americans, Asian Americans, Hispanics were more likely to answer not sure or don't know to sexual identity questions. And Asian Americans and Hispanics were slightly more likely, but significantly more likely not to answer. But Native Americans, Alaska Natives, and non-Hispanic whites had very similar odds of non-response. So it is important that we do educate people about these, about sexuality and gender and these questions, and that we also make sure that we're really getting culturally inclusive measures. So we do suggest there's inclusion of sexual orientation, also gender identity, related measures for all ages, including older adults. And it's important that we look at multiple dimensions of sexuality. So we look at sexual identity, we look at sexual behavior. We also look at partnerships and romantic relationships. We also include both gender identity and expression. And we look at non-response patterns, and we do consider and think about the cultural sensitivity of sexual and gender identity questions. And so all of that's important as you think about adding questions into your own research or your own practice. We were funded by the National Institutes on Health to move forward this area of research. And so we were funded to conduct Aging with Pride, the National Health, Aging, and Sexuality Gender Study. It was the first national study of its kind in the US and frankly, in the world. But we have now been able to move that study to a longitudinal study. But our very first step was using population-based data, so actually looking at existing data sets to understand health disparities. And today, the definition here, differences in health outcomes encountered because of systemic obstacles to health, such as social, economic, and environmental disadvantage. The reason we wanted to understand the health disparities first was so that we could ensure that then as we acquire more information and try to understand the risk and protective factors, we know what we are trying to, which disparities that we are focusing on and trying to improve health outcomes. Now, it's been very important to us to look both at what works in this community, where there's challenges, but also what works. So I will also be talking about the factors and how many in this population are doing very well, because we don't want to oversimplify and think, because there's disparities on a population health level, that means all LGBTQ people are experiencing these disparities. That's not true. In fact, the majority do have good health, but they do have higher rates of health disparities than the population at large, and compared to heterosexuals, or what I'll call cisgender people. So people that are not LGBT or T. We also wanted to understand demographic differences. And so we wanted to use the population-based data to do that. So in the first studies, they didn't have gender identity questions. So we're looking at lesbian, gay, and bisexual older adults. And we do find that they have higher levels of education. And we look in Washington State now, we're also seeing higher levels of poverty. But yet that's very interesting. You have higher levels of education. And why is it that you would have higher levels of poverty? We also see they're much less likely married, and that's still that is true today, even though there's marriage equality, but they're more likely to be partnered. And we see that older lesbians and bisexual women compared to heterosexual women have higher likelihood of employment, and older gay and bisexual men have less children in the household, and they're much more likely to live alone. So when they next wanted, and there was national data that became available to look nationally at chronic health conditions. And we found that lesbian, gay, and bisexual older adults have higher rates of 9 out of 12 chronic conditions. So older lesbians and bisexual women had greater likelihood of stroke, heart attack, asthma, arthritis, low back and neck pain, weakened immune system, higher number of chronic conditions overall, more likely to have multiple chronic conditions, but lower likelihood of diabetes. And we also found that we did then want to understand the differences, because even though lesbians and bisexual women may have those, when they're combined, have these more chronic conditions, we wanted to understand if there was differences. And sure enough, older lesbians compared to bisexual women were more likely to have stroke, heart attack, and arthritis. When we looked at older gay and bisexual men compared to heterosexual men, they had more likely to have angina pectoris, low back and neck pain, cancer, weakened immune system, less likely to be overweight or obese. So there was also some positive health indicators, and a likelihood of a weakened immune system. Actually, the overweight and obesity was higher among gay men than older bisexual men, and lower back pain was higher among the older bisexual men. So the reason I'm pointing this out is, again, so that you can see the kinds of differences we see in these populations. Of key health indicators, we found a greater likelihood among older lesbians and bisexual women of poor general health, disability, and mental distress, and also a lower likelihood of limitations in ADL. But I want to say something about this disability, and that was, we did end up looking as young as 18, and these groups do have higher rates of disability as early as 18, so that's something that progresses into old age. And older lesbians were more likely than older bisexual women to have poor general health and disability. And older bisexual women more likely to have the ADL limitation. So again, we see these distinct kinds of differences. And compared to older bisexual men, compared to heterosexual men, older gay and bisexual men also were more likely to have a disability, ADL and instrumental ADL and IADL limitations, and mental distress. And older gay men were more likely than older bisexual men to have ADL limitations. while older bisexual men were more likely to have mental distress. So we wanted to understand what is maybe some of the behavioral health issues that are important to understand as we try to unravel both why these disparities, but also what kinds of interventions will be most critical for these older adults. And the older lesbians and bisexual women, we found more likely excessive drinking, more sleep problems. They were also, though, more likely former drinkers and former smokers. So obviously there's people change, and that I'm surely likely improving health. Also more likely to have insurance coverage. Remember, they were more likely to be employed, more likely to have some important screenings, blood pressure screening, HIV tests. So again, it suggests these points of potential intervention. And older lesbians were more likely than older bisexual women to be former drinkers. So again, this is similar with the older gay and bisexual men. They were more likely current smokers, more likely to drink excessively. But again, they had some more preventative behaviors, likely more flu shot, more HIV test. It's a good opportunity in clinics to be able to ensure that they have the latest information on behavioral health. Also, older bisexual men were more likely than the older gay men to be current smokers, and older gay men more likely than bisexual men to get an HIV test. So our goal was to understand the elevated risk for chronic health conditions and then be able to identify and target them for prevention. And again, targeted prevention and intervention programs are certainly needed to be able to identify sexual minority and gender minority, which I'll talk about in a minute, transgender older adults. But more like it's important to be able to identify those at greatest risk. And if we can understand the health needs of the older sexual and gender minorities, as well as those specific to the subgroups in the populations, that can help us to use this information to develop effective preventative interventions and services tailored to their unique risk and protective factors. Again, race, and we very early on stratified the sample in our longitudinal study, and we stratified it purposely by age to make sure that we had 3 cohorts. So those in midlife, 50 to 64, those 65 to 79, and those 80 and older. But we also stratified our sample by race and ethnicity when we first started this work, and we've continued it both in our longitudinal study as well as in our population-based work, so that we do really understand by race and ethnicity what the differences are. Because as I said before, with LGBTQ older adults, many studies and interventions weren't tailoring anything to their needs. They assumed they had the same general needs. We did not want to do the same thing within this population. So that's why these subgroup differences were so important for us to look at. So this was a study that was conducted by Dr. Ha-Joon Kim, who's the director of our research. And he wanted to compare Hispanic heterosexual women, both to Hispanic lesbians and bisexual women. And he found both that the Hispanic lesbians and bisexual women were at greater risk for smoking, lifetime asthma, disability. And that Hispanic bisexual women, again, higher rates for arthritis, acute drinking, frequent mental distress, and poor general health. But most of the health indicators for Hispanic lesbians and bisexual women were similar to the non-Hispanic white lesbians and bisexual women, except. So here we're trying to disentangle what is occurring because of race, but also what is really occurring because of sexual identity or sexual orientation. And here we found that the Hispanic lesbians and bisexual women, Hispanic bisexual women more frequently had mental distress, more frequently had mental distress, while the Hispanic lesbians more frequently had lifetime asthma. And also that we found the higher prevalence of smoking, obesity, and mental distress in Hispanic lesbians may in part explain this cumulative risk of lifetime asthma, So that will be important for prevention as well as earlier intervention. And among Hispanic bisexual women, the cumulative risk related to multiple marginalized statuses appear to lead to greater mental distress. So that's just an example of how important it is also to look at race and ethnicity in this case. So as I said, we now have a longitudinal, while we identified what the disparities were in our initial community-based survey, we wanted to understand the risk and protective factors. Now this study has now been funded for the 10th to the 15th year. It's interesting because at one point people felt people wouldn't participate in the study, but in fact it's been, the opposite. We actually, we have some of the highest retentions of any longitudinal study. But what we found is that compared to, and here, to older gay men and bisexual men, older lesbians and bisexual women, again, had elevated risk of disability, obesity, lack routine checkups, lower rates of smoking and excessive drinking, but lower rates also of lifetime victimization, internalized stigma, more social support, and larger social networks. But that elevated risk of disability was important because it surprised us. We thought, in part that gay and bisexual men have higher rates of disability, just the potential influence of HIV and, some of those factors. But in fact, older lesbians and bisexual women are very high rates of disability, but they do have some really important protective factors, especially larger social support networks, more social support. And compared to older gay men and lesbians, older bisexual women and men had higher levels of internalized stigma, sexual identity concealment, and lower levels of social support. And this was important because we did not know that bisexuals would be the most likely to not disclose their sexual identity or their sexual orientation to providers. We didn't have any idea, but they have some of the very highest rates of sexual identity concealment and not sharing their sexual orientation with providers. And you may be aware of, but the American Medical Association, came out with a very strong statement about the failure to disclose one's sexual orientation or the failure to ask on the part of the provider. Both can lead to poor health consequences. But what we did find is that, for poor general health, there are financial barriers to healthcare, so access becomes an issue. Smoking, obesity increase the odds. Not having an annual routine checkup and engaging in physical activity decrease the odds. And this is one thing that's also a very important point of intervention for this community, because they do tend to be engaged in higher rates of physical activity. And that's even for people who are overweight or obese, they have much higher rates of physical activity. And so that is a good point for potential intervention. But what we see happening, and one of the strongest risk factors that we see in our work is lifetime victimization, and then also ongoing bias, either through microaggressions or people feeling that they're being treated in an inferior way, but both the lifetime victimization, the discrimination, and then some of the more subtle forms of bias. But we also see important protective factors, increased social support, social network size. As I already said, they were more, the lesbians more likely disabled, more likely financial barriers. But what we find for depression is, again, that it's very similar, and you can see how these factors are cutting through. So that's actually helping us figure out ways to be able to address the needs in this community. So for depression, and much higher rates of depression in this community, and psychological distress, both in the population-based data, but also in our community-based surveys. But again, linked to financial barriers to healthcare, so lack of access through due to financial barriers, higher rates of obesity. Again, if engaging in physical activity decreases the odds. But these unique factors, that lifetime victimization and discrimination, feeling a sense of shame or internalized stigma, and then the protective factors, increased social support network size. One other protective factor that I didn't list here, but it's also community engagement. And that community engagement, particularly in the LGBTQ community, is a very protective factor. And so that helps us know what factors to be able to ensure that we work into our interventions that we want to tailor to their unique needs. Because you can see through all of this, some of it's the general factors that we would see for all older adults. But as we look at the more unique and risk factors, there, we do identify what those unique risk and protective factors. And then it's our, our work then is to make sure that we're being responsive to both those general concerns or risks, but also to those more specific to this community, which more often than not are not included in interventions. We've been also following, as part of this group, we're following a cohort of gay and bisexual men primarily living with HIV, because about 9% of the sample is living with HIV, including 14% of gay men and 21% of bisexual men. And the African, Black, and African Americans and Hispanic participants were more likely to be living with HIV than those that are white. And the likelihood of HIV decreases with age. But it's been very interesting and important to be able to follow the course of living with HIV for older adults. And while they are at risk, they do display a lot of risks in terms of higher rates of poverty, lower levels of education, more disability, poor general health, cardiovascular disease, cancer, and hepatitis, poor mental health, depression, anxiety. They're more likely to live alone and experience higher levels of loneliness, more likely to have experienced the death of a partner, both early in life or later in life, and also less social support, lower likely partnered or children. So it's a very, potentially a group that is at very high risk. And so we have been working to be able to understand this information to be able to apply to develop some interventions, because the community support piece here is very important. And many of them, I just want to say, during the height of AIDS and early on, many of them lost their support system, lost their partners or friends. Some recovered really well, but we have a very large group or cohort that has never recovered from really that period, and they tend to be very isolated and very much at risk.
Dr. Fredriksen Goldsen, I'm wondering if I can jump in with a question that might help some attendees moving forward, and that is, sure, are you using the terms sexual identity and gender identity interchangeably, or do you define them differently?
Oh, no, I do define them differently. So sexual identity really is how one thinks about their own sexual identity. And so, and that's, their own self-report identity. So their sexual identity. So that would be lesbian, gay, bisexual, or sexually diverse. Some people might consider themselves pansexual or sexual diverse. So that's how I'm talking about, that's what I mean when I'm talking about sexual identity. When I talk about gender identity, it's, what's one's own, sense of self and their gender. So do they consider them, so for gender, do they consider themselves a man, a woman, or non-binary, neither man or woman, okay? Or do they consider themselves transgender or not? We do ask people if they consider themselves transgender, trans, or gender identity diverse. So that's what gender identity means. And no, that's a really important distinction. And so I don't use them interchangeably. But I do want to say another important thing for gender is also how people express their gender. So you may hear me say gender expression. So it's really important when that's how they express their gender. So their mannerisms, that type, that's more gender expression. So we look at all of these factors. We look at sexual identity separately from gender identity. because you can be transgender, so looking at one's gender identity, if they identify as transgender, and they could be, you know, gay, lesbian, bisexual, or sexual diverse. So they're separate terms. And it used to be early on, people would ask a question: how do you think of yourself? You know, gay, lesbian, bisexual, you know, or transgender. But see, that is conflating sexual identity with gender identity. So we do want to separate those. And on our website, we do have some resources for people. And we did do a special issue for the gerontologist. And in that special issue, we do define terms. So if anybody wants to learn more about the population, there we define terms, we define the measures, and we also have some fact sheets that do that too, so that it's easier for people to grasp. Great.
Thanks. And I put your website in the chat.
Oh, great. And Barb, if you have anything else like that, a clarifying question or whatever, please ask. I'd be happy to you know, clarify. Now, here is where I'm getting into gender identity. So remember, we do ask people, you know, if they're transgender or not. And we also ask people their gender. So if they consider themselves a man, a woman, or non-binary. And we do see, even among older adults, this increase in people who do consider themselves gender non-binary. But here, this is really looking at transgender people compared to those that are cisgender. And by cisgender, I mean non-transgender, okay? And for transgender women, they are at risk in terms of socioeconomic risk, low income, less education. And they're more likely to live alone, have fewer children, and more likely to have poor mental health and general health, and higher odds of disability. And I'll tell you a little bit about this. First, I want to talk about the transgender men compared to those cisgender. They're younger and more likely single, lower income, less education, increased risk of poor chronic conditions, and more likely poor mental health. Again, the main factors that we'll see in this is that issues of discrimination and bias that they face. But remember, for transgender older adults, there was a time in medicine that if people had a transition, and not all transgender people transition, but for those transgender people that do transition, in other words, transition from one gender to another, and that could be elective surgery, you know, or not. If they have transition, there was a time in history where providers asked or suggest, you know, really recommended that transgender people not take on an entirely new identity, leave their existing support structures, anyone they know, just leave and completely start a new identity. So it does created some risk for transgender older adults in particular. But we do look at this growing number of people, as I said, they're still transgender, but they're not non-binary. And you can have this in the groups, any of the groups we're talking about, but where they don't, they do not consider themselves a man or a woman, but they're non-binary. And in fact, we see this increasing rapidly in college at early adulthood and among college students. But we do see that they're younger, more likely single. This is of the transgender older adults. They do increase risk for poor mental health, poor physical health, and disability. And when we compare transgender people to the lesbian, gay, or bisexual older adults, part of the risks that we see is they have higher lifetime victimization, higher lifetime discrimination, more internal stigma. So by internal stigma, they're feeling that they often don't belong, that they feel of less worth. They're more likely to conceal their gender identity. They have higher rates of financial barriers to healthcare services, and they fear accessing health services outside of the LGBTQ community. 40% of trans older adults really fear accessing any kind of health services outside of the community, more often based on, you know, their previous experiences of receiving biased care. We also know they have actually larger social networks. So they have some very good things going on. Larger social networks, more likely to have virtual networks, less likely to live alone, and they have more likely to have children. Although in some cases, they may be close to their children, in some cases they may be estranged from their children. But even though they have those protective factors, they still have lower levels of social support and lower levels of community belonging. It's interesting how many transgender older adults have served in the military. And it's important because actually the military, not for all transgender people, but for many has been a very protective factor and is associated with better health and better mental health. But overall, the population is at risk. Again, it's very highly associated and tied to the rates of victimization and discrimination. They find poor physical health, greater likelihood of disability, more psychological distress, and more perceived stress. Also higher rates of obesity and more lack of physical activity. So overall, for transgender people, you really do have to understand when we think about gender identity, or we think about the health risks and the health disparities, and we are just having a paper published in Washington State now that looks very specifically at transgender people in the state, and both transgender women, transgender men, and transgender non-binary people, and looks at these health risks. But we see that the victimization and the discrimination are the greatest, they're most highly associated with these poor health, along with this sense of internalized stigma and this fear of accessing services and the lower level of physical activity. And again, this concealment of gender identity, as I said, is very important too, because many people, they're providers. Many avoid health services in general, but if they are in health services, they conceal their gender identity. And again, as I said, they have lower levels of social support and community belonging. But the important thing here about these disparities from our perspective is that we have to understand the strengths in these communities, but also address the common health risks, again, faced by older adults in general, but also the unique risk and protective factors affecting LGBTQ older adults. And as I mentioned, this lifetime victimization, lifetime discrimination, increased stigma, and very different and distinct support networks. So they're much more likely to have friends as care providers. And many times friends have shared that when they are a care provider, they don't receive the same respect, or they feel they don't receive the same respect or concern that a biological family member would, or a spouse. So it's important to think about the different family structures also. But they do display, older adults, remarkable resilience. As many have shared, they built the communities that now are enjoying the kinds of changes that they have seen. But the vast majority are very satisfied with their life. They're aging successfully. They have strong personal and social ties. About 90% feel really good about belonging to their communities and have at least moderate levels of support. I think all of this is really important because when we look at disparities, and you have to understand the disparities, but at the same time, you don't want to oversimplify and think everybody in these populations or communities are having problems. That's not the case, and most feel very satisfied with their lives. And also, as I said, 90% are involved in leisure activities. 8 out of 10 engage in moderate physical activity. That's really high. And we're building the physical activity. Already people are exercising, but they're very amenable to physical activity. So we can build that into our interventions. 38% are involved in regular spiritual or religious activities. And interesting that transgender and bisexual men have the highest involvement in spiritual and religious activities. And the caregiving rates are extremely high, both for men and women. And they primarily rely on partners and friends. That's not to say that they're not also caring for other biological family members, or that they're not being cared for by other types of family members, but they rely heavily on their partners and their family of choice, or friends that extended kin, or and friends. Now, we also looked at and wanted to understand, historically what's happened. And most LGBT older adults, certainly those 65 and older, came of age when homosexuality was stigmatized and criminalized. And most were likely experienced very pervasive silence about their identity, both just in the larger social discourse, but they also had periods where their identities were pathologized. They were subjected to institutionalization, criminalization, castration, or lobotomies. So, it makes sense that many do have real fear about working or accessing care. Now, those that are aged 50 to 64 came of age during tremendous social change, right? So they're really the baby boomers. They were more visible socially, politically, and they were more likely to disclose their identity. But because of these two different kind of historical paths, we do have very different, they present very differently. But a lot of people thought, well, because of that history, the older adults themselves, those 65 and older, are going to have a lot worse health outcomes. Well, actually, we found that the outcomes are very similar across both the baby boomers and what I'll call the silent or the invisible generations. And the reason being is that those 50 and 64 had much higher identity disclosure. So they're much more likely to be out about being a sexual or gender minority, and they have higher social support. But because in some ways of both of those factors, there are much higher rates now of overt victimization and discrimination. And that victimization and discrimination continues to be linked to the poor physical and mental health. And this is why when we look across the oldest, but we also look across baby boomers, they both are experiencing relatively similar health disparities. And that was something we learned from this, and it has surprised the field. But it is very important to realize it, because in some ways it creates being able to be open and disclose, it creates freedom, less stigma. But if the result is bias, victimization, or discrimination, you're going to have the same kind of levels of health disparities. And while many LGBTQ older adults have spent most of their lives concealing their sexual orientation or sexual identity and gender identity, they are a population at risk. But they're at risk in part, 82% have been victimized at least once or discriminated against. 66% have been victimized or discriminated against 66% 3 or more times. So you can see the level of victimization and discrimination in their lives. 89% feel positive about belonging to their communities and are really engaged in a lot of our efforts because they want to make a difference for their communities. As I've already said, the discrimination, the stigma, is very highly associated with the poor physical and mental health and disability. 4 out of 10 had experienced thoughts of suicide. And so it's really important, LGBTQ older adults do talk about the unconscious bias that they do experience in when accessing care. So it's really important for us to think about us as providers. Is there any kind of unconscious bias? We have a pretty good article on unconscious bias, but how it could be related to sexual or gender identity, or to the LGBTQ status or their age. And a lot of older adults, LGBT older adults talk about, you know, how invisible they do feel because of their age. And many people don't understand that LGBT people can be older. And so it's even missed. People are less likely even to pick up on people's cues or whatever if they're a sexual or gender minority. Age is a factor here, and it's very important, as it is for all populations. But what is unconscious bias? So it is those negative experiences during treatment or when attempting to access healthcare that likely influences, you know, subsequent interactions with a healthcare. So it's those negative experiences. And 15% are fearful about accessing healthcare services of LGBTQ in the community, but 40% of transgender older adults. And the older you get, the more likely you are to be fearful. And 13% were denied healthcare at one point in their lives, so they are bringing that experience. 25% have not revealed their identities. Remember, it's even higher with transgender and bisexual people. But in general, 25 have not revealed their identities. And that, as I said, with the AMA, can have adverse health consequences, because if you don't know somebody could be at risk for something, it's very difficult to educate them about that. And those that are 80 or older are most likely not to disclose their identity to a physician. So it really does require building a trusting relationship. Many people will respond and they'll share how they identify if they're asked. But again, it should only be asked if it's a very safe environment. And it's important to acknowledge and understand unconscious stereotyping does persist in healthcare delivery and contributes to disparities, because these unaddressed biases can really result in forms of victimization, discrimination, microaggressions, feeling you're being treated with less respect. And we can all be prone to unconscious bias because it's the biases we may not understand. Now, there's very good training programs. We have one in our own institute for providers, but there are good training programs that really help providers look at their ideas or stereotypes. Or my experience is that most providers, not all, but most providers really want to serve this community well. It's just they may not know how to. So they may not be able to see or understand if they're acting or if there's unconscious bias, and they may not know or have the skills to make sure they're providing affirming services. So we do have training for that, but when we think about competencies, how can we be good providers? I always feel like we talk more about what we should do, people should do, than really showing them what to do. So we took the information that we have and we have developed a skill-based training program so that people have the cognitive and behavioral skills to provide affirming services. But we do know that practitioners have ethical mandates to be knowledgeable in working with diverse populations. So the more exposure people can get to communities, the better. It's really important that content relevant to their lives be included in training programs. It's still largely absent. It's changing somewhat, but if you look, it's still largely absent. And it's really, there are standardized comprehensive competencies and to be able to address the needs and the challenges and be able to support the resilience and resources within the older LGBTQ community. So one thing is that, and this is, again, there's training programs to walk people through this, but really be able to critically analyze personal and professional attitudes. Learn what these, and I'm glad the person asked the question, what does it mean? What do we mean by, sexual orientation, gender identity, and age? What are our personal and professional attitudes? And how do we understand these factors and how they play out in our culture and our religion and our media or our health or human services. All of that influences our attitudes and our ethical decision making. And can we understand and articulate the ways that larger social and cultural contexts may have negatively impacted LGBTQ older adults as a historically disadvantaged population? And again, they're very resilient, but they have been in many ways marginalized through parts of our history. So it's important to understand that and be able to understand it, but not be able to only view the person through that lens. So it has to be both understanding of it, being able to see the, person-centered, see the person in front of you for who that person is. And maybe they haven't had these experiences, or maybe they have built such a strong support network that, they are doing very well. It's important to be able to distinguish the similarities and differences within the subgroups. Again, people usually think of the LGBT as monolithic, and that's why I did spend quite a bit of time today to make sure people can see the differences and the similarities, because there's intersecting identities, age, gender, race, ethnicity, health status, and we have to consider that and develop their tailored and more responsive health strategies. We also want to understand and apply theories of aging and social and health perspectives and most up-to-date knowledge available to engage in culturally competent practice. And while I'm only providing an overview here, I do want to note that I put citations here on most of these slides, and there's all these articles where you can get right off our website, get a lot more detailed information. It's a little too much to be able to do in this short time, but I'm giving you the good, good overview, understanding, but there's a lot more of in-depth information available to you. But when we do conduct comprehensive biopsychosocial assessments, it's important to attend to the ways that the larger social context, structural and environmental risks and resources can impact LGBTQ plus older adults. And again, by that, what has been the experience? What has been people's experience? How stigma impacted their lives? As I said, those environmental risks in the context, those victimization, the exclusion because of social policies. People can marry now, but many older adults never had a chance to marry with their partners. And in a way, the policies excluded them from resources and benefits. So it's important to understand that. And I know we all work towards using empathy and sensitive interviewing skills during assessments and interventions, but you really do have to listen to the language of the person. People will ask me, well, do you just come out and ask a person? I listen to a person for the language they use. If I know that it's a safe environment, I do ask about sexual identity and gender identity, as long as I know it's a safe environment. But you can also listen to the language they use and ensure that use of language is appropriate for that person, and it can be used to build and establish a rapport and ensure that they feel safe in the environment. We also want to understand and articulate the ways that an agency, program, and service policies do or do not marginalize or discriminate against LGBTQ older adults. One is just how safe does it make people feel, but also if there's, all the services for, let's just say, people with dementia and their family caregivers, but they're all written, for spouses or for adult children, you may miss about 40% of the LGBTQ older adults who have a friend helping them. That's just an example. But you also want to be able to understand and articulate the way the local, state, and federal laws negatively or positively impact LGBTQ people, older adults, and our responsibility to be able to advocate on their behalf in our agencies or organizations, as well as at other levels. It's important to provide sensitive and appropriate outreach to LGBTQ older adults or family caregivers and other supports. You probably won't see very many people in your services if you don't, or they may be there, but you won't know they're there. And that's what I have a lot of people tell me, that they want to be supportive, but they don't have any patients or clients like this, or that are gay or lesbian or sexual or gender minority, but usually they're there, they just may not be visible. It's really important to enhance the capacity of LGBTQ older adults and their families, caregivers, and other supports to navigate aging, social, and health services, because this community has really, it's survived in many ways on their self-reliance or reliance on their own communities. But remember, on their peers, tend to have very peer-based support, either, as I said, through friends or through partners. But as they're all aging, they are people that have been providing support and would have supported them through anything, may also have their own chronic health conditions, or they may lose these people to death, and so these long-term survivors are at risk. So it's really important, their self-reliance and their reliance on their communities has got them to where they are today. That was a very important way they survived, but it's also important to know when and how to navigate these systems and be able to get the help one needs. And moving forward, there's only now are we getting good population base. So I'm only now are many of the surveys at the national level even adding a gender identity or transgender questions. But we really need to pay attention to the gender and sexual diverse older adult populations, those that are identifying as non-binary. As I said, that number is growing, and it's important that we understand that. And there's a lot of issues about environmental and structural safety, promoting privacy through access to bathrooms they can use, and also not focusing on all interventions on downstream or on the individual, but also looking at upstream, what we can do culturally to support these older adults and their communities. I just want to tell you a little bit about some of our next steps. So as I said, with the longitudinal study, our goal was to be able to get the information we need to be able to understand the risk and protective factors, and then make sure there's interventions that are supportive. So I'm just going to give you one example. And one of the groups that we found at greatest risk are older adults, LGBTQ+, older adults living with dementia, memory loss, Alzheimer's disease, or other dementias. And again, they're at very high risk for memory loss, cognitive impairment. We've now been able to document it in population-based studies. In fact, there are disparities in subjective cognitive decline and in cognitive impairment, which is a good indicator of potential dementia later in life. So there are disparities, and this community has a lot of risk factors, right? That higher smoking, drinking, living alone, these high rates of social isolation, the psychological distress. They've got a lot of the risk factors, HIV, there's a lot of risk factors, and many, it does have higher rates of dementia. So we actually collaborated with Linda Terry, who had a very successful RDAD, reducing disability and Alzheimer's disease. So we collaborated with her, and we were able to get an R01 funded to look at, does a traditional program like RDAD work for this population, or what if we compare it to one intervention arm or an intervention where we enhance it and we actually respond to using motivational interviewing to engage. And then we have modules that really relate to that victimization and the discrimination people might have experienced, how they reveal or don't reveal their identity. So right now we're testing that. It does look very promising. The enhanced, we call it innovations in dementia empowerment and action. That if we are responsive to those unique risk factors in this community, that there's better outcomes, especially for groups that are the least likely to access services. So we also found out that about 40, now most dementia programs are built for, a person living with dementia or their caregiver, and most caregivers are family, biological adult children or spouses. We found that equally number of friends are providing care. But what was really surprising is we found that 40% did not have anyone that could participate with them. So they're living with dementia, they're living in the community, but 40% don't have anyone that could participate. So we just tested a group, and it's for Idea Cafe for those living alone with dementia for no care partner. And now we're also testing another intervention for Idea Cafe. So for those for care partners or caregivers, but they don't have a person living with dementia. So we're going to have 3 different kinds of interventions that we have tested. And then as long as, well, the preliminary information is that they're successful, but we have to, or that there's efficacy, but we have to finish that analysis. And if they are, we'll move those to scale. But again, that's just to give you an example, the way we can use this intervention, this information, but develop interventions that are tailored to their needs. As I said, we do have a lot of fact sheets and resources on our website. So there's a great deal of information there for you that you can easily access. We also have, there's been more than 100 publications from that study. So there's lots of different publications, but we also are really committed to making sure that this information can be used in a way that benefits practice. So we also did a special issue for the generations on generation. So it has some real good articles for practitioners. We also did a special issue for the gerontologist. And in that really really outlines the science behind this project, but also defines a lot of terms and also the kinds of measures that we used, and really outlines the research that we've done. But there are a lot of different resources on the website, so please take a look. And if you're not finding what you need, let us know. And as I said, we also have what is now been funded by King County as an Age Pride Center. So in collaboration with Gen Pride, we are really take some of these interventions, some of the things we've learned, and then translate it back out to the community. So both, primarily locally, but because there's not been a lot of this work that's been done to this extent elsewhere, there's also people that utilize this nationally and internationally. But there is the Age Pride Center, and it's right on 41st and UA, and it's open. And that's also a place you can stop by if you want to get more information, or you want to get, we have a resource guide there. There's lots of information, and it's a great place to also to refer people to if you know people in your practice. And we also have the training, which started out as the Safe Home training. So through DSHS and CMS, they funded us to provide a training in long-term care facilities. And we opted to do a training that addresses people who are sexual or gender minorities, but also we really do a lot and look at race and ethnicity as part of that, and really help providers there learn cognitive and behavioral skills for creating culturally sensitive environments. And so that's also, it's called the Safe Home and Safe Care Training. So that is also available. So here's our social media contact information. So feel free to join us. And then there's my information and our institute information if you have questions or you need additional information. Thank you.
Thank you so much, Dr. Fredriksen Goldsen. This was just so important to hear and also just incredibly interesting. I wondered if I might start off some of the questions by building on what you were just saying about training in skilled care and that sort of thing. I'm wondering what you're finding from your data about living in residential communities and those sorts of aging in place transitions that older adults go through, and how that has been for LGBTQ communities.
No, I think that's a really important question. Many of the older adults are very reluctant to transition to any kind of supportive living. Not all of them, but many of them are very fearful of that, and many have had and shared some bad experiences. And because people have really, you know, kind of their self-reliance has often kind of got them where they are today. It's so important that we connect with people and we connect where they're at, and then we help them understand what's available. And then also that we know places are well-trained and can offer good, you know, care and safe care. And then we share that with people, these older adults that may be out in the community. We do have ways to reach them. Many are isolated, but as I said, they do want to help better their communities. And it's really important that we use innovative ways, and we use through community outreach workers and such to be able to connect with people. But I think the thing is, people may have stereotypes of their own they're bringing. And so it's really important that we can show and provide access to transition, to the potential for transitioning to services when they need it, but that we know that they're safe and that they're going to, you know, provide inclusive care. We have just recently in Seattle, based a large part on this work, at least according to Mayor Durkin, and because we did do a housing module study, and we did find that how reluctant people were, but people really wanted affirming housing. So now a affordable housing unit is being built on Capitol Hill that will be the first LGBTQ affordable housing. And but again, we want to make all services inclusive and safe. That's the goal, right? Because not everybody wants to. Also, there's many older adults, you know, that want to live in, you know, communities with all kinds of people. And so, you know, it's just important that we have options, but that does require some training and you know, being able to ensure that it's safe.
Thank you. Received a question earlier on, and it was about when you were talking about social networks and comparing larger with normal social networks. This came from Lisa Love, who is a former student of yours and sends you greetings. She was Lisa Balloon at the time. But she's wondering, do you have a heterosexual control group for comparison to determine what size of a social network is normal, or for making those comparisons?
Hi, Lisa. Nice to hear from you, and thank you for being part of the audience today. We do, because we have, it depends which study I'm referring to. Some of it we just do with LGBTQ older adults, but we also have done some work, you know, where we're comparing to non-LGBTQ older adults. And the social networks, it's complex because you can have a very large social network and you can still have very little social support, or you can have a small social network and have a small social network and have good social support. So we found you really have to look at those two together to find, you know, if people have good social support and they do have a large social network, that is what's really important. Again, it depends which subgroup in the population we're talking about. For example, with transgender older adults, they tend to have very large social networks, and before COVID or anything, that many of them had a network through virtual online, and so it enhanced the size of it, which was very large, but it did not necessarily enhance the quality of the support. So we do look at both of those. So thank you, Lisa.
And Beth is just saying that she's really happy to have access to all of the resources that you've identified, and there are a tremendous number of resources on your website. Erin is asking about terminology and mentions the fact that it's been difficult more recently to use the queer word because growing up it was thought to be somewhat derogatory, and now it is part of the LGBTQ vocabulary. Can you help us a bit with that, Karen?
Sure. I think that's such a good point. And I always say, if I use the LGBT, the acronym will be outdated before I finish a talk. And it's the same thing if I use LGBTQ, because these language really evolves. And I couldn't agree more. A lot of older adults, queer was very derogatory. It was really used to bully people. So a lot of people have a very negative connotation. I tend to use it now because, well, I use it for queer and questioning because there's still a lot of people that come out later life. And so that's also important for people that may be thinking or considering their sexuality. So for the questioning, but I also use the word queer, and I did not use it for a long time just because I know how that some people it could be hurtful. But we have our study ranges in age from 50 to 102, and everybody 90 and older I've interviewed myself. And when I went to interview the person that was 102, I asked, well, how do you identify? Because identity and all the terms, it's really can be difficult. And he looked right at me and he said, I'm a queer. And from that time on, I went ahead and added the Q because I want to use language that's inclusive. But I also know that it can come with baggage. And there's still some people that really prefer to be called homosexual. And there's some people that don't identify with any of the terms. I had a couple that had been together for 50 years and they called each other their liaisons and they didn't identify with any of the terms. So language is very tricky, and that's why it's always important to listen to the language of the person in front of you. But I also think it also reduces stigma when we start to use language. So it's a very good point. We do have a directory at our institute that is going to be made available real soon, and it's called Words Matter, and it's all the terms, because people throw around, and I apologize if I too was throwing around terms and then our terms change even in the field. So we do have this Words Matter. So if you need something, you let us know, but it will be on our website. It probably won't be there for about 3 weeks, but in 3 weeks, Words Matter will be there, as will a resource directory for this entire area.
Well, that'll be great. I look forward to that. Lisa had asked about some of your data. You were talking about baby boomers, and it got me to thinking about when your data was collected. You said you're starting into your 10 to 15 years. And so some of these data, were they coming from people 10 years ago? And so it's a broad range of age groups, both in terms of who was eligible, but actually how long ago some of the data were collected. Do you know what I mean?
Yeah, I think I know what you mean. We've been in the field with the longitudinal. We did one piece of this before, cross-sectional, but we have been in the field 10 years, and we do our survey every other year. And so, the most of the trends that I've been sharing, though, the language may change, how people identify. And in fact, we're working on a piece right now about identity and how it changes over time. But the majority of the findings still are, really accurate. even in the most recent waves of that study, most of those, I don't want to say trends, but most of those findings are accurate. It's just now what we're able to do is look over time. So now we can look, we can look at trajectories. So we can understand if a person started here, what kind of trajectory did they have over the 10 years? But some of those more basic findings about the different age groups are consistent. But remember, we have cohorts. And so we are following 3 very separate cohorts in this study. So we are following one cohort that was the baby boomers, the 50 to 64. We're following, I do it by birth year. I just don't have it in front of me. It's roughly 50 to 64. And then another cohort that we call the silent generation, and that's about 65 to 79. And then we have the silent cohort, or that's 80 and older. So we look at age effect, we look at cohort effect, we look at all of the different, for a longitudinal study, we have to consider all of that. It's only now that we're getting to the point where we can actually isolate age from cohort, because now we're 10 years. So we're all in those analysis. I'm sorry if I'm answering you more than you wanted on that, but it is an important issue, and we do replenish. So now we don't have the people age 50 to, the younger age group. So now we're in the process of replenishing that our sample. So we will always have 50 upwards, 50 and older. Did I answer you, Barb?
Yeah, I think so. I mean, I actually, Lisa's mentioning 50-year-olds or Gen Xers, and I have to admit that I got very confused typifying these cohorts in that way. But
yeah, they are now. But when we started, they were really in the baby boomers. So yeah. Right now I'm talking about those people that were baby boomers. Now we will add other generations. And in fact, we have a project now that's 18 and older, because we decided that we really wanted to find out also what was happening before 50 that was leading to a lot of these disparities at 50. So we are looking at earlier cohorts, earlier age groups, I should say. So, there's always, but it is important, and, it does change. But like I said, what was the most surprising is, even though we were looking at different cohorts, or I'll say even different generations, what we were finding is that the disparities were remaining relatively constant. It was just different configurations of risks and resources.
Mm-hmm. Interesting.
So it was configurations of risks and resources that were changing, but their risks, because there's still a lot of bias and victimization and discrimination. And I know sometimes in Seattle or wherever, we might not think that's the case, but it really is. And they still experience a lot of certainly invisibility, but also just a lot of bias experiences. So,
well, it's nice to hear that there are networks that can help guide LGBTQ older adults to living situations that are friendly,
yes.
As well as that there are a lot of residential settings that are trying to become more aware of how they can more appropriately offer services for older adults, LGBTQ older adults. So
exactly. And there's been a lot of steps to reduce, isolation and invisibility, and that makes a big difference.
Mm-hmm. Well, I really want to thank you. This, as I said, this has been such important information for us to hear. And I know that you've got data coming out all the time from your studies. And I was just on a conference call today where somebody in Minnesota was talking about how they use your data all the time. So I really want to thank you. This has been great. And I encourage everyone to take a look at the Goldsen Institute website, because there are just some tremendous resources. And I wish you all a great evening, and I will see you next week.
Thank you. And thank you, everyone. Thank you.
Thanks,
Barb.
Karen.
Bye-bye.
Bye.